Okay, well, welcome to class. We're going to go ahead and take a look today at the appendicular skeleton. And, before we start, does anybody have any questions on anything related to our class or anything in general? I've received a lot of emails. I'm working my way through those emails. If you're concerned about your test grade, I will give you an answer. And try to explain what's going on. And if you didn't do as well on the first test as you would have liked, two things to keep in mind. There are 3 more exams with numerous opportunities to improve your grade. And second of all, lab grade is not as critical, if at all, because the lab grade has nothing to do with admission to any of the programs. You can pass the lab with a C, that's not going to hurt you. Your lecture grade is the important grade for getting into any of the healthcare programs you might be looking at. I can't emphasize that enough. Lab grade has a minimal impact on your overall GPA, but not very much. So obviously try to do your best in lab, but don't stress over it. As long as you can, even a C isn't going to hurt you in lab. A C in lecture will hurt you, no matter what they tell you. A C in lecture will hurt. An A in lecture or a B in lecture is what you want, but a C in lab is not going to hurt you. Okay, enough of that. Let's go on and talk about the appendicular skeleton. And those are the bones of the arms and legs, hands and feet, fingers and toes that we have in our bodies. And let me close that and open this up. There we go. And the appendicular skeleton, we'll start here with the clavicle. The clavicle, or our collarbone, is located right up here at the top of the thoracic cavity. You can feel your collarbone if you place your hands on either side of your shoulder. In the front, you can feel that ridge of the top of your collarbone, or the clavicle. This is clavicle. It articulates on the sternum and on the scapula. The scapula, of course, is your shoulder blade. You can see your shoulder blade here, just in shadow form here. But it has 2 structures to it. It has a flat end and a thick end. The thick end is the sternal end. There's the acromial end. That articulates on the flat structure known as the acromion on the clavicle, on the scapula, your shoulder blade. And the other end is the sternal end, and that articulates on the sternum. So if you look at the animation here, you can see the flat end of it is going to articulate against the flat end of the scapula. You can see when it goes around, it's a pretty good example there. And the thick end of the clavicle articulates with the sternum itself. It helps to form the joint. It helps to form the pectoral girdle. The pectoral girdle consists of the head of the humerus and the scapula and the clavicle. And it gives us this great range of motion around our shoulder. So, and we call it the pectoral girdle for the pectoral region. So this is part of it. So this is the clavicle. It leads out in front. It's frequently broken. It's frequently, you can damage it easily because it's sort of leading in the front here. You can feel it. You can feel it under your skin. It's right up there in front. So we know where it's located. The thick end is the sternal end. The flat end is the scapular end. The flat end is the lateral side, the side away from the midline. So the side that's over here near your shoulder is the acromial end, the lateral end. the end that's near your sternum is the medial end or the sternal end. Okay, so now this is our scapula. This is our shoulder blade. You can even feel your shoulder blade. If you reach your hand behind your back, behind your shoulder, you can if you find the top of your shoulder and go slide backwards, you can feel a ridge back there. And that ridge is the spine on your scapula located right here. Why is it doing this? Let me see. See if I can fix that for us a little bit. There we go. Okay, now let's try it again. Now, the first thing we notice on the scapula is the socket for the head of the humerus. We call that the glenoid cavity. It's not much of a cavity. It's more of a fossa, more of a flat area. But that glenoid cavity is where the head of the humerus articulates with the scapula. Now, this big flat area here is called the infraspinous fossa. Infra means below. Remember the infraspinous. I'm sorry, the infraorbital foramen on the front of the skull. Well, infra means below. So this is the flat area below the spine. This is called the spine, right along in here. So if you have an infra, you're going to have a supra. And eventually we'll see the supraspinous fossa because there's a flat area above the spine. Now, all of these flat areas here are the locations of some pretty powerful muscles that we use all the time. They fill up these fossa. There's our spine. That spine that you can feel, and you rub your hand across the back here. And if you reach below the spine, you can feel the muscles, some of the muscles that are located on or in the infraspinous fossa. There's the spine. There are two processes here. One I've already mentioned, that's the acromion right there, the acromion process. It's a flat process. The flat end of the scapula and the flat end of the clavicle articulate together in the front. We have our pectoral girdle in the front of the shoulder area. We have the flat acromion articulating with the flat clavicle. Below the acromion is another process called the coracoid process. It's more of a rounded structure. Both of these, as in all these processes, are going to be the points of attachment of muscles and ligaments and tendons, because this whole area is surrounded by a great big capsule made up of muscle and ligaments and tendons and cartilage in here to hold this structure together, because this is not much of a socket to hold that head of the humerus in place, but it also gives us this tremendous flexibility at our shoulder. There is the vertebral border, the edge of the scapula. Its medial border is almost touching the vertebrae. It's not really, because it's on top of the ribs, but it's that close to the vertebrae. So we call it the vertebral border. And if we have a medial border, we're going to have a lateral border, and that lateral border is called the axillary border because it's near our axilla. The armpit region doesn't go into the armpit, but it's on that side. That whole area under our armpit is called the axillary or axilla. And there's our axillary border. We have an inferior angle. If you have an inferior anything, you've got to have a superior something. So you're going to have a superior angle up here at the very top of that flat area. So There's a superior border, and if we have a superior border, we have to have an inferior border. And show it, but that's okay. So superior border here, inferior border would be down here because we have, if you have a superior, we have an inferior. So what do you need to remember on these structures? What are the most important things to remember? Well, first of all, the glenoid cavity. The glenoid cavity is where the head of the humerus articulates with the scapula, our shoulder blade. That's the first thing to remember, the glenoid cavity. The head goes in here. The next thing to remember is the acromion, the flat area coming off the spine of the scapula. It articulates with the flat end, the acromial end of the clavicle. There's the clavicle there. There's its flat end right there. And the area highlighted in green is the flat area off of the acromion. See, because this whole structure helps to make what we call the girdle. The clavicle, the scapula, and the head of the humerus. So the coracoid process is directly below the joint of the, it does not articulate against any bone. It's directly below the clavicle and scapula, where it comes together here at the two acromial ends, there and there. But there's the coracoid process there. Again, attachment of muscle and connective tissue, ligaments and tendons, and so on. Now, the area above the spine, this is an important structure to know, is called the supraspinous fossa. This is the spine, right along in here. The area above the spine, supra, above, spinous, spine, and fossa, flat area. Supraspinous fossa is the flat area above the spine. This area down here is the infraspinous fossa, the flat area below the spine. Both of these two areas are where we find very powerful muscles that help our arm to move in all directions. And those muscles are named for the bones that they're laying on. The supraspinous fossa has a muscle on it called the supraspinatus. The infraspinous fossa has a muscle on it called the infraspinatus. You'll hear all about them when we get into the muscle section. But there is the supraspinous fossa above the spine. Now we take a look here at our scapula. There's the glenoid cavity. There's the acromion, a flat end. The other one is the coracoid process. There is the axillary border closest to the armpit. There is the spine of the scapula right here. And that makes that the supraspinous fossa above the spine and the infraspinous fossa below the spine. Infraspinous fossa, inferior spine, supraspinous notch, and supraspinous fossa and the medial border. So what do you need to remember in all this? Well, obviously the supraspinous fossa, the infraspinous fossa, and the spine of the scapula, as well as the acromion, the coracoid, the glenoid cavity, and the spine of the scapula, the supraspinous fossa, the infraspinous fossa. We look at the posterior, at the other side of the scapula, the side that is set. Remember, the scapula sets on top of your ribs. This is looking at the surface that sets on the ribs. This area here is called the subscapular fossa, another important structure. It's the flat area underneath the scapula, subscapular fossa. And the muscle that sets there is called the subscapularis. If you've ever heard of the muscles called the rotator cuff, these are the subscapularis, the supraspinatus, and the infraspinatus. are three of the four muscles in the rotator cuff. We're going to talk about them a lot when we get into muscles here. But there's the subscapular fossa where the subscapularis is located. It's the flat area underneath the scapula. Suprascapular notch again. Superior angle, inferior angle, axillary border, vertebral border, coracoid, acromion. Remember the acromion's a flat one. And there's the glenoid cavity right there. The acromion is the one that articulates with the clavicle. Superior border, and we have an inferior border down there. Taking another look at the underside surface of the scapula. There's the subscapular fossa. This is the side of the scapula that is going to be laying on top of the ribs. The spine is on the other side. This flat area is the area that butts up to the ribs because the scapula sits on top of the rib cage, helping to form our shoulder. You can feel your spine, the spine of the scapula, when you rub your back at the shoulder. Just come down a little bit below the top of the shoulder and you can feel that spine right there. You can't feel your ribs back there because the scapula is sitting on top of the ribs. The subscapular fossa is the side of the scapula that's flat and butts up against the rib cage. That's what this is. Suprascapular notch again. Superior angle, inferior angle. Axillary border. Remember, the axillary border is flat and the vertebral border is curved. Coracoid, that means the other one's the acromion. Acromion, you can see really well the acromion is the flat one. And the glenoid cavity. So, you need to know there's three big fossas that you see there, the supraspinous, the infraspinous, and the subscapularis, subscapular fossas. That's going to be this. That's going to come back again later on in muscles to tell you what those muscles are named, because those muscles are named for those fossa. You need to know the acromion and the coracoid. You need to know the glenoid cavity. So I have to be able to identify the spine. So subscapular fossa, the supraspinous fossa, the infraspinous fossa, the spine, the glenoid cavity, the acromion, and the coracoid. Those are all key structures to remember. Key structures to remember. Now, our humerus is the large bone of the upper arm. The head of the humerus, this round structure over here, articulates in the glenoid cavity. It fits into the glenoid cavity. It's a very loose fit because it's very flexible, extremely flexible. We can rotate our arm around our shoulder almost a full 360 degrees because of the shape of that girdle, the pectoral girdle, and the cartilage and muscles and ligaments and tendons that are holding it together. So one of the prominent structures on the humerus, besides the head, is this structure sticking out over here. Now, this is called an epicondyle. Remember I said with the skull, bone processes that move up and down or are in an up and down position, anterior, posterior, vertical, whatever. Those are called condyles. If they extend from medial or lateral sides of the bone, they're called epicondyles. This is an epicondyle. This is the medial epicondyle. How do I know that? Well, the head of the humerus is always on is on the medial side of the bone, the side closest to the midline of the body. So the head of the humerus is medial. That's the head. Anything lined up with the head is medial. Anything on the other side is lateral. And if you have a medial epicondyle, you're going to have a lateral epicondyle, and that's this bump over here. That's the lateral epicondyle. If you have a medial condyle, you'll have a lateral condyle. You don't have condyles on the humerus. Let me say that again in big letters. You don't have condyles on the humerus. You have an epicondyle, a medial, and an epicondyle, a lateral. But you don't have condyles. Now, these other two structures here, you have what's known as the trochlea, and the one directly below it, closest to the lateral epicondyle, is called the capitulum. There's a reason I'm going to mention these. You like having an elbow that works, don't you? And you like to have your trochlea and capitulum in place. So medial epicondyle, lateral epicondyle. We know this is a medial because it's lined up on the same side as the head of the humerus here. Directly behind the trochlea and capitulum is a depressed area called the coronoid fossa. I'll come back to that a little later on. We have a bump. We have a large bump on the shaft of the humerus, and that large bump is called a tuberosity. And what we have here is what's known as the deltoid tuberosity. That's the point where the deltoid muscle, the large muscle on your shoulder, attaches to the humerus. That's its point of insertion. So when a muscle attaches to a bone, we call it, where does it insert? And so this large bump that you see about halfway up the shaft or halfway down the shaft of the humerus is the deltoid tuberosity. That's where the deltoid muscle, the muscle that comes over your shoulder, the muscle where you get injections. If you had any injections lately, it usually went into your deltoid muscle on your shoulder. That's the deltoid tuberosity. This little bump there near the head is called the lesser tubercle. We only have tubercles on the humerus. Little bump there, a point of attachment for muscles. Lots of muscles are attaching to the head of the humerus. If you have a lesser, you got to have a greater, and the greater is right there, separated by a groove, the groove between the tubercles, the intertubercular groove. Okay, now there's the head, and it's sort of interesting. I don't know if it's interesting or not, but the lesser tubercle is closer to the head than the greater tubercle. We'll see something similar to that on the femur. They're going to have a lesser and a greater bump also. They're not called tubercles. I'll point it out to you when we get there. But the lesser structures tend to be closer to the head than the greater structures. So there's the head on the medial side of the humerus. Since the head always goes into the glenoid cavity, the head's always on the medial side. So if you're trying to remember which is medial and which is lateral, all you have to remember is that the head is always medial. You can use that then for your landmarks. If the head's medial, that means that's medial. It means the epicondyle is medial. That tells you that the one over here is the lateral epicondyle. And that, if you remember, it tells you that this is the trochlea and that's the capitulum. Okay, so, and the head tells you that the bump closest to it is the lesser tubercle and the one away from it is the greater tubercle. And the bump in the middle is the deltoid tuberosity. So there's your greater tubercle. There you see the head articulating in the glenoid cavity. This is the greater tubercle. That's the lesser tubercle right there. Points of attachment for muscles. Lots of muscle attachments on the head of the humerus, because our humerus does so many things. We rotate it around, we use it all the time. Now we're looking at the posterior surface of the humerus. Still the head is on the medial side, right there. We have another flat area on this side called the olecranon fossa. Again, this has to do with our elbow. This is still the medial epicondyle here. This is on the same side as the head of the humerus. It's still the medial epicondyle. This is still the lateral epicondyle out here. The trochlea is still next to the medial epicondyle. And the capitulum is still near the lateral epicondyle. There's the lateral epicondyle. There's the head of the humerus. Oh, didn't show it. And this is the capitulum right here. Lateral epicondyle, medial epicondyle right there. Again, doesn't matter which way we're looking at it, anterior or posterior view of the humerus, whatever's lined up with the head is on the medial side. It doesn't matter. So whether it's anterior view or posterior view, if it's an epicondyle lined up with the head, it's a medial epicondyle. Now we move down a little further. We take a look at one of the most distinctive bones in the body. This is called the radius. The head of the radius is a round structure. It almost looks like a stamp. You would stamp things with. It has a round head. There's no other bone in our body except the other radius that looks like this. It's one of the two bones of the forearm that allow us to turn things like opening doors, turning the key in the ignition, which we don't do anymore. Most of our ignitions are push button, but turning a doorknob, for example, or even pressing down a latch. Most of us still have doorknobs. So the rotation of our arm at the elbow and wrist are a result of the shape of the radius. We can rotate our arm around this radius here. This is the head of the radius. This is the neck of the radius. The area below the head is always called the neck. This area here is called the radial tuberosity. You can't tell from this picture, but there is a bump there. You'll see it here in a second. If you look at as it goes around here, you can see a little bit of a bump every time it goes around. Here, you'll see that better in a second. There's the head. There's the neck. Underneath the head, there's the radial tuberosity. Down here at the other end is a styloid process. Remember the styloid process from the skull, the pointy end of the bone? Well, we have one on the radius. We have one on each radius. We have one on each of the ulnas too. The other bone is called the ulna. And there's the radial tuberosity located right where the arrow is pointing, by the way. Just wanted to point it out to show that, to give you an idea. If you look carefully, you can see the bulge here. Now you'll see this styloid process. Now here is the radial tuberosity right here. What the radius does is it rotates around at the elbow, so it can turn the whole arm over, so we can grasp onto a doorknob and turn it. Any kind of turning motion we want to have with our hand. The head of the radius rotates here around the capitulum. Rotates around the capitulum. There's the capitulum. There's the trochlea. There is the lateral, I have that right, lateral epicondyle. And we are rotating around that because it will pivot over top. See how it crosses over. And here you can also see the styloid process very nicely right there on the radius. There's also one in the ulna here. You can see the radial tuberosity as it bulges out right there. So this is what the radius does. This is what the round head does. It rotates around the capitulum and allows our movement to occur with that rotational movement. Another view of the radius. There's the radial tuberosity. There's the styloid process at that end. There's the head. There's the neck. There's the radial tuberosity. You can see it again right here. Green highlighted structure right there is the radial tuberosity. Now the other bone of the forearm is also extremely distinctive. You can almost imagine it looks like a socket wrench. This is the ulna. This works with the radius. Now the ulna, no other bone looks like this except the other ulna, the other arm. The head of the ulna is called the olecranon process. Below that is a coronoid process, and there's a notch there called the trochlear notch. Now, the olecranon process, we know it better as the elbow. If you take your hand and rub your elbow, you're rubbing your olecranon process. This structure right here is what forms our elbow. The elbow is found on the ulna, and it wraps itself around the trochlea. The trochlea is, you have the trochlea and the capitulum there at the end of the humerus. The radius rotates around the capitulum to give you that radial motion. The olecranon process, our elbow, moves around, rotates around the trochlear notch, or the trochlea at the trochlear notch. So it gives us that back and forth motion there. The ability to pull our arm up or lower our arm down is based on movement of the elbow. So if you feel your elbow, you're feeling your olecranon process. Of course, there's the styloid process on this one too. And again, that's a point of attachment for muscles. Now, let me let's go back here one more. Show you this again. There. Now let's go back. Now again, see, there's your ulna. We don't see it moving here because the ulna is going to, instead of rotating, the ulna is going to be increasing or decreasing. It's going to bend when you bend your arm. When you bend your arm at the elbow or extend your arm at the elbow, that's where the ulna comes into play. Because there is the trochlea down here, and the ulna is going to rotate, is going to pivot at the trochlea. Either extending the arm or bringing the arm back to your shoulder. Of course, there's the radius there. So these are the two bones of the forearm that give us this incredible range of motion with our hand. Now, if you know where your thumb is, you can find your radius. There's your thumb right here. So there's your thumb. The thumb lines up directly with the radius. Even when it rolls over, the thumb lines up directly with the radius. So now you can find your radius. So you know where your thumb is, you know where your radius is. You know that underneath your radius is the ulna. So now you know thumb, radius, and ulna. Now, if you remember that the radius articulates against the capitulum and the ulna forms your elbow at the olecranon process, now you know two more things. And if you know the olecranon process, you know where your trochlea is. Now, later on, when we get further in, particularly in AP2, if you know where your thumb is, you know where your radius is. If you know where your radius is, you know where you can take your radial pulse right behind your thumb. That means that's where the radial artery is located. And if you have a radial artery, you have a radial vein. And the radial vein runs right beside the radial artery. And underneath the radius is the ulna, with an ulnar artery and an ulnar vein. So all of a sudden, just by knowing where your thumb is, now you know where your radius is, your ulna is, your radial artery, your ulnar artery, your radial vein, your ulnar vein. You know where your elbow is, your olecranon process, and your trochlea and capitulum, just by knowing your thumb. And it's the same on both arms. So let's get past this. And, down here to the hand. Now the hand is pretty simple. The hand is made up of 3 sets of bones, and the fingers themselves are called the phalanges. The good news is the toes are called the phalanges. The bones between the wrist bones and the phalanges are called the metacarpals. There are only 5 of them. They're called the metacarpals. And the bones of the wrist are called the carpal bones. So phalanges, metacarpals, and carpals. I'm not going to ask you to learn all 8 different carpal bones. To me, a lot of these bones look the same. You know, later on, you know, you may have to learn them to be, you know, another challenges. But right now, you know, we have a lot to cover, and we don't have, you know, 8 little bones of the wrist. It's enough that you remember that they're the carpal bones, because here are the names of them: the trapezium, the trapezoid, the scaphoid, decapitate. And I always think there should be a decapitate, but there isn't. The hamate, the lunate, the triquetral, and the pisiform, which is the other half of the triquetral. So somehow, if I do ask questions, nobody ever gets the pisiform wrong. Anyway, the point is, there's a lot of names to learn here, these little structures, and a lot of them all look the same. Now, you will have to know the tarsal bones of the foot. And there's a reason for that. I'll get to that later on. So, okay, so these are the bones of the wrist, but as far as I'm concerned, if you can tell me that they're the carpal bones, I'll be happy. Okay, this is a female pelvis. Female pelvis has very similar structures to the male pelvis, but the female pelvis is wider. And I'll go through the particulars here in a minute. But this is this is distinctively different. Most of the pelvises that we have available for review are going to be male pelvises. I don't know why. That's just what we encountered. When I came here 18 years ago, that's what we had. It took years of asking for newer models. These things are expensive, by the way. They're really expensive because they're handmade in Germany, and that's beside the point. The point is that we do have some models now that are correct in shape. They're not real. These are not real skeletons, by the way. They're very, very good models. So this is a female pelvis. The structures are pretty much the same, just the shapes are slightly different. So, okay. So what do we see here? Well, this first bone is called the ilium. This is the largest of the 3 bones that make up the pelvic girdle in here. This is the ilium. And this is the iliac crest. This is the edge of the bone. If you put your hand down on your side, right about the midline of your leg, just back from the pocket area, you can feel the crest of your ilium. You can feel the iliac crest very easily on the side of your hip. That's the top of the ilium on either side. There's the sacrum, the end of the spinal column. and below that is the coccyx. The sacrum is 5 fused vertebrae. The coccyx is 3 fused vertebrae. They combine, the sacrum combines with the ilium to form the sacroiliac joint right here. There's the pubic bone here in the front, and it forms, the two pubic bones come together with a pad of fibrocartilage to form the pubic symphysis. There's the ischium, the third bone. We have the ilium, the ischium, and the pubic bone or pubis. And we have one on each side. And the structure here in the middle is called the pubic symphysis. Now this is the sacroiliac joint. This is where the ilium and the sacrum come together. The shock of motion, the shock of movement up our legs is absorbed in the front by the pubic symphysis, this pad of cartilage here. In the back, it is transferred from the acetabulum to the ilium to the sacrum, through the sacroiliac joint, and then up the vertebrae, where the shock of motion is absorbed by all these intervertebral discs in here, and it doesn't hurt to walk. It doesn't hurt to walk or run or move. And so we have two types of shock absorbing actions for our motion. One here in the front with the pubic symphysis, and the rest with the sacroiliac joint and the pads between the vertebrae, because we bring the shock of motion up our spinal cord column and use those discs as shock absorbers. Of course, there's the pubic symphysis. That's the junction of the bones with that big pad of fibrocartilage right in the middle. Big gap in here is called the obturator foramen. We have lots of nerves and blood vessels that have to move down our legs. We have lots of nerves and blood vessels that move down our legs and come up our legs. And they have to move into the abdominal cavity. They have to connect with the spinal cord. And so they have to have a way to get through the pelvic girdle. And the obturator foramen is that structure. It allows the passage of blood vessels and nerves that are trying to connect with our legs. Of course, there's one of our lumbar vertebrae. This is the socket. This is called the acetabulum. The head of the femur, the largest bone in our body, articulates in the acetabulum. Now this is the pubic arch across here. The shape of the pubic arch is distinctive. In the female pelvis, it is shaped like an inverted bowl to allow for the larger passageway of babies through the birth canal. In males, the male pelvis, the pubic arch is like an inverted V, like a pyramid structure. Indicates the pelvis has a narrower shape, a more narrow shape than narrow, a more narrow shape. So a very distinctive difference. The inverted V is the male, the inverted bowl shape is the female. There's an intervertebral disc now. Okay, the coccyx right there. This is the true pelvis. And as opposed to the false pelvis, which runs from iliac crest to iliac crest, right there. The pelvic brim is the area, is the edge of the true pelvis. And of course, pubic arch again. Now, looking at the posterior surface, we have the sacrum, we have the coccyx, the ilium, the ischium, and the pubis. And the pubic symphysis is right here in the middle. And the pubic arch. Again, an inverted bowl as opposed to an inverted V for the male. coccyx, iliac crest, ischial spine. There is a spine there. You might be able to feel that, but not like the crest. So, okay. Lateral view of the hip bone. This is at one side. It's been separated. They're separated here. The ilium, the iliac crest, anterior spine. There's the acetabulum right there. That's where the head of the femur articulates with the hip bone, or the coxal bone, as we say. Pubic bone, obturator foramen from this angle. There's a reason that I want to show you this picture. It's coming up here, and this large notch right there is the greater sciatic notch. The sciatic nerve passes from the spinal cord. The greater sciatic nerve comes up, is derived from the spinal cord and it passes through the sciatic notch and extends down behind your knee and all the way to your great toe. It's about the size and about the thickness of your index finger. So it's a very large nerve made of lots and lots, thousands of axons. And this is the notch it passes through as it proceeds down to the great toe, or comes back up from the great toe. The greater sciatic notch, and this is a branch of it here. This is the lesser sciatic notch. So it does branch a couple times already. So now there's our femur right there. There's the femur, the largest bone in our body. It has a head, and same rules apply. The head of the femur is on the medial side, just like the head of the humerus is on the medial side. So there's the femur, there's the head of the femur, there's the neck of the femur. Now the neck of the femur, among other things, is where most hip fractures occur. When someone breaks their hip, when grandma trips on the rug in the kitchen and falls down and breaks her hip, she usually is fracturing the neck of the femur right here, because osteoporosis has likely eaten away much of the bone underneath the surface, dissolved most of that bone. So the neck is pretty fragile. So this is the area where most hip fractures occur. Technically not the hip, but that's what we refer to as a hip fracture, is breaking the neck of the femur. Yeah. So is it a life-threatening injury? Used to be that the neck of the femur was treated, 50 years ago, the neck of the femur was treated just like any other fracture. You have to repair it and pack it with extra bone tissue from other parts of the body, and then immobilize it and put grandma into a body cast and keep her in the hospital for 6 weeks or 8 weeks or 10 weeks or whatever. Well, what would usually happen is that grandma would develop pneumonia because she was flat on her back and she couldn't swallow properly, and she would aspirate fluid into her lungs and develop pneumonia and die in a week. Now, when someone breaks their hip, breaks the neck of the femur, they have surgery, they have an artificial hip put in, and they're up and moving, being forced to move the next day. And they go home in 3 or 4 days. They don't die, usually. Totally different approach now, the treatment for a broken hip. So conventional wisdom 50 years ago, totally different from conventional wisdom today as far as treating fractures like that. Movement is key to survival. Okay, moving on. Now, we had the tubercles in the humerus. We have something here called the trochanters. We have the greater trochanter, and we have a lesser trochanter. And the lesser trochanter just like the lesser tubercle is closest to the head. The head's in the medial side. The lesser trochanter is on the medial side. The greater trochanter is on the lateral side. It's further away from the head. Points of attachment for muscles. Lots of muscles attach to the head and neck of the femur. The intertrochanteric line, and there's an intertrochanteric groove on the other side. We'll see it here in a second. Here we have the medial epicondyle again. We have a medial epicondyle on the femur. We know it's the medial epicondyle. First of all, we know it's medial because it's the same side as the head, and it's an epicondyle because it extends to the lateral and medial sides, because the lateral epicondyle is there. So we know it's an epicondyle because it goes out to the sides. We have a medial epicondyle on the same side as the head. That means the other bump on the outside is the lateral epicondyle. When we flip it over, though, we're going to see processes of bone that go up and down. And those are going to be condyles. Like here, there's, on looking at the posterior surface, there's the ends of our bone right there. This is the end. This is the head of the femur right there. There's the greater trochanter there. There's the neck right there. This is the lesser trochanter because it's closest to it's on the same side as the head. And here we have the intertrochanteric crest. We have the line on one side and the crest on the other side, on this side. Couldn't remember if it was the groove or the crest. I apologize for that. Looking down at the end closest to the knee, here we have the medial condyle. Same side as the head, it's the condyle. It's like the occipital condyle. It's up and down. That means the other one is the lateral condyle. We still have the epicondyles. There's the epicondyle there and over there. This is the medial epicondyle right there and the lateral epicondyle here. But since these are up and down, these structures actually rest on top of the pads of cartilage set on top of the tibia. And there's a fossa in between the condyles, by the way. Okay. Now moving down, let's take a closer look at the end of the femur and the tibia and the knee. So here we see the patella. There's our kneecap. There's our femur right there. There's the patella, the kneecap. Here we have the most useless bone in our body. That's the fibula. It doesn't do anything. It's not load bearing. It does no support. All it does is get broken. It forms the outside surface of the ankle. There is no ankle bone. There are no bones called the ankle. We have a structure called the ankle, which consists of the end of the tibia, end of the fibula, and one of the bones of the foot. That makes up the ankle joint, but there is no ankle bone. And if you're going to break your ankle, you're going to usually going to break the fibula down near the process of the ankle. Okay, there's the fibula, and the bone that does all the work in the lower leg is the tibia. You can feel your tibia if you put your hand down and rub it across your lower leg at what we would call the shin bone, and that is the crest of the tibia. And there's the tibia again. And here we can see this is the lateral condyle right here. And again, and there's the medial condyle right here, lined up on top of the tibia. And the epicondyle is out here and out here. How do I know that's the medial condyle there? Because it's the side opposite from the fibula. The fibula is always on the outside of the leg. So there's your fibula, the most useless bone in the body. When the fibula is laying out by itself like that, it's almost impossible to tell which end is which end. Doesn't look obvious. The only thing that the fibula does for us is produces the outside of the ankle. There's the head of the fibula, and this is called the lateral malleolus. The lateral malleolus. If you want to feel your lateral malleolus, put your hand down on your ankle on the outside of your foot on the little toe side. Find your little toe. Put your hand down on your ankle on the little toe side, and you are touching your lateral malleolus, because the lateral malleolus and the medial malleolus, which is on the tibia, surround a bone called the talus. The three of them form the ankle. And so your lateral malleolus is this little bone on the outside that you can feel. Now there's your tibia, the hard worker of your lower leg. The crest of the tibia, the anterior crest, you can feel it. It's that sharp edge that you feel when you rub your hand down across the front surface of your tibia, of your lower leg. That's the anterior crest of the tibia. You can feel that. We find it often late at night in a dark room when we discover that somebody moved a table in front of you when you didn't see it. So when you walk into things, we often call it our shin bone. That's the common name for it, the shin bone, but it's really the anterior crest. Close up of the tibia. There is the medial malleolus. If you put your hand down on your ankle on the big toe side of your foot and touch your ankle on the inside of your foot, you are touching the medial malleolus. Very thick, powerful structure. This sits on the other side of the bone called the talus. So this is the medial malleolus. Its counterpart is the lateral malleolus. There is no bone called ankle. There's the medial condyle and the lateral condyle next to it. This is where the cartilage pads called meniscus sit. They're located. They're shock absorbers, so that when the head of the femur, when the condyles of the femur are pressing against the condyles of the tibia, there's no pain, there's no friction, because these cartilage pads here, the meniscus, are in place. Lateral condyle, and there's the anterior crest of the tibia and the tibial tuberosity right there. And again, we can see what these condyles look like here on the end of the tibia. Now we're almost through. Here we're looking at the foot. Now, a way to remember which side is medial and which side is lateral. The big toe side of the foot, if the leg is, and this applies also when we get into muscles, and we're looking at a whole leg model. We're looking at a whole skeleton model. The big toe side is always the medial side. That's your landmark. You can use the head of the femur, you can use the head of the humerus. Those are on the medial surfaces. The great toe, the big toe, is always on the medial side. So we have, first of all, we have our phalanges right there. Same name as on the fingers. We have the metatarsals, similar to metacarpals, and we have the carpal bones. Now, the carpal bones, three of them share the same name. We have the medial cuneiform, we have the intermediate cuneiform, we have the lateral cuneiform. So behind metatarsals 1, 2, and 3, you have the medial, intermediate, and lateral cuneiforms. Behind the cuneiforms, you've got the navicular, and over here you have the cuboid. So it's a little easier to remember that these bones. There seems to be more of a pattern, more rhyme and reason to this. Medial, intermediate, and lateral cuneiforms. The navicular is behind medial and intermediate, and the cuboid is behind is next to the lateral cuneiform. And that's nice. The two most important bones here, at least from our perspective, are going to be the talus and the calcaneus. There's the talus, it's the bone that sticks straight up. And the calcaneus is the one that forms our heel. This is the calcaneus here. See, this is the calcaneus sticking out back here. The talus is hidden. The talus is between the medial malleolus and the lateral malleolus. This is the end of the tibia right here. This is the medial malleolus. There's the talus jutting up between the medial and the lateral malleolus. The fibula is on the other side. You can't really see it. However, we can see a number of structures here. We can see the medial cuneiform, the intermediate cuneiform is right beside it. Here is our navicular. Can't see the cuboid or the lateral on the other side, but we can see at least three of them here. But we see the talus right there, jutting up between the two medial and lateral malleolus, and we see the calcaneus. Now the calcaneus, our heel bone, is the bone that our Achilles tendon attaches to. It's what allows us to raise and lower our foot. So there's the calcaneus. And the calcaneus, important structure. If the if the Achilles tendon is severed, our foot flops. We can't raise or lower our foot. So it's important, an important location. We'll talk a lot about that when we get into muscles. The talus is the bone in between the two malleoli, the medial and lateral. You didn't see me say ankle anywhere. I guess if you could see me say it. The point is there is no bone called the ankle bone. The ankle joint consists of the talus with the medial and lateral malleolus. The lateral malleolus is always on the outside, so from the fibula. The medial malleolus is from the inside, from the tibia. This is the medial malleolus right here. Here's the cuboid sticks down there, and that is the appendicular skeleton. Any questions? Okay. I am going to be going over to campus later today or in the morning to make sure that we have bones available in room 217 for people to observe and manipulate and play with. So I'll have, as soon as I have that nailed down, because I thought I had it, but apparently I didn't. So I will take care of that. I will make sure it happens this time, and I'll let you all know tomorrow. So anyway, that's all I've got, and I'll let you go. And looks like the rain has finally stopped too. So, and I'll see you all later on.